pain management group really takes a service line approach to pain management. And so there are interventional, fellowship-trained pain management physicians that work both in interventional pain procedures, but then also provide judicious use of medication management, wrap around with ancillary services, which these patients clearly need to improve function, and then ultimately put guardrails around safe use of medication. This is a snapshot of referrals, patient visits to pain management groups, hospital-based departments across 2011. When House Bill 93 was signed into law, we saw a one-time 39% increase in patient referrals. The better takeaway from this slide is about the 17% growth that continued throughout the rest of the year. This is the impact of being a community resource to PCPs, to neurosurgeons, et cetera, and them knowing that they have a colleague that can kind of sit at the helm of that patient care experience and take that portion of care and treat it, which for primary care physicians is something that they were seeking and a pretty big deal. Kind of the risks and exposures that exist for your hospital system and how to mitigate some of those risks. The first would be relative to the 50+1 rule. Any percentage above 50% for a physician's practice, they would need to register as a terminal distributor of pain medicine. It can be a very difficult, time-consuming patient population that might take away from their ability to manage strep throat and heart disease and all of those things that are truly kind of the life-threatening things that they need to be addressing day in and day out for their communities. Because these PCPs might not accept these new patients with a chronic pain condition, or if they decide they're not going to prescribe medications any longer for them, they're going to show up in your emergency departments. That emergency department needs to deal with emergent issues and life-threatening conditions. But when a physician prescribes, they should be looking at ORS, the Ohio Automated Prescription Reporting System. Hospitals are not exempt from using that system. When it gets to the pharmacy, the hospital pharmacy, ethically, the right thing to do for patients is to pull up ORS and to do a double check. When you query a patient, you get a list of who prescribed what medication, where it was filled, the quantity that was filled. You'll be able to see the prescriptions that were filled and the quantities and the number of doctors that they had kind of cycled through on their quest for care. Anybody that's doing that body of work needs to be aware of what they're providing patients and make sure that they are providing appropriate dosage and safeguard. For the safety of the community and just diligence, it's much better to utilize the system up front and safeguard the communities. And I would suggest to you that the impact of House Bill 93 for hospitals is opportunity. When I look at what opportunity exists related to House Bill 93, it's coordinating a care system for these patients, which is going to provide better quality, and it's going to be a better service to the community as a whole.